Thank you, Beth. And I thank the organizers for inviting me to speak at this symposium, and welcome to Mount Sinai. The left ventricular assist device use has increased over the past 10 years, and if one wonders why that is, it's because of the excellent job done by my colleagues in the coronary intervention lab and the electrophysiology lab, where the patients are now living longer and as a result continue to develop heart failure and end up having end-stage heart disease where they require an intervention. And with that background set up, these are my disclosures. And the way I have set up the next 20 minutes is to introduce you to left ventricular assist devices. More importantly, take this information along with the patient that we are all familiar with, and then look at what evidence is there for the use of LVAD, and then to look at what patient population that we can implant these devices, and are we making any difference in the patient's life. Here's a patient that we are all familiar with. This is a 54-year-old man referred for transplant evaluation with a 4-year history of heart failure, dilated cardiomyopathy, with a New York Heart Association functional class 3 or 4 level of activities, and 3 admissions for acute decompensated heart failure in the past 9 months. Now that in itself would tell us that this gentleman is returning to the hospital quite frequently with decompensated heart failure. Then when one looks at the echocardiographic findings, his ejection fraction is about 15%, with significantly dilated left ventricle at 7.4 centimeters, bivalvular regurgitation in the form of mitral and tricuspid regurg, and right ventricular dysfunction. He has renal insufficiency, most likely as a result of cardiorenal syndrome, and a borderline blood pressure of 100/75. His liver is palpable as a result of congestion, and he has 2+ edema. From a medication perspective, he is optimally treated for heart failure. Now this is an example of the type of patients that come to our service for end-stage cardiomyopathy, where extension of life and improved quality of life is become more important at that point, because they are looking at increased mortality from their end-stage cardiomyopathy. So what does transplantation do? Transplant improves quality of life, but more importantly, it extends a life of a patient who would otherwise not be looking at more than 5 years of life with end-stage cardiomyopathy. If this is the data from the International Society of Heart and Lung Transplantation, that we know if the patient survived first year after the transplant, they have a half-life of 14 years. They have a 50% chance of living 14 years, which is an improvement in extension of life as opposed to medical therapy alone. That is a very desirable effect if they are transplant candidates. But what happens if they are not transplant candidates, and what happens to these patients? This is a data that was published almost more than 20 years ago by Mancini when she was in Philadelphia. They looked at 3 groups of patients who came to the transplant center to be transplanted. Out of those, group 1 is a group that was tested for functional capacity and eligibility for transplant by means of doing what is called a cardiopulmonary exercise testing. This is a test that tells us whether a patient needs to be listed for transplant at that point in time, whether they will benefit by transplantation, and if there is a transplant benefit from extension of life, survival benefit. Group 1 is the open diamonds, are the patients who had a VO2 of less than 14 on a functional capacity assessment. The number 14 for VO2 is utilized as a cutoff point for listing for transplantation. If you score less than 14, then you will be listed for transplantation. If it is more than 14, then we defer the patients and will not list those patients for transplant and continue to follow them more closely until they drop the VO2 less than 14. These numbers have changed slightly over the last few years with the use of beta blockers in heart failure, and I won't go into the details of those. It's sufficient to say, for our purpose today, we will keep 14 as the cutoff point. When one looks at this graph, at 12 months, the open diamonds, those are the patients who were listed for transplant, they had a survival of about 60%. But when you look at the closed triangles here, which are patients who scored less than 14, by that number they are eligible for transplant, but they are not transplanted because they were deemed non-transplant candidates due to other comorbidities such as diabetes with end organ damage or renal insufficiency. If you looked at the survival here, their 12-month survival is about 40%. Out of this understanding came the question, what can we do to extend life for the patients who are not transplant candidates? And we'll bypass this question. And the second question was, even if they are transplant candidates, as you saw in the previous data, patients die on the waiting list. The bridging technologies, until a heart becomes available, were not sufficient enough to bridge all the patients to successful transplantation. If one looks at this, I apologize for the busy graph. This is a lot of data here with regard to different era, starting at in the early 90s to late 2000s. The blue graph, blue lines are the patients who are transplanted. The green lines are the patients who are still waiting on waiting list. And clearly there's a separation between the two lines. If you get transplanted, your survival is better on the waiting list as opposed to if you're waiting for a long time. And this was the problem. How could you bridge these patients to successful transplantation so that we can extend their life? It is the same for class 2 patients who are listed as class 2. Class 2 meaning non-urgent but require transplantation ultimately. Class 1 patients means these patients have a increased mortality within the next 6 months to a year. The rematch trial published in 2001 came out of these two questions. How can we provide extension of life for patients who are not transplant candidates? And how could we bridge patients who are transplant candidates to successful transplantation? So what was looked at here is left ventricular assist devices. At that time, it was pulsatile devices. HeartMate 2 was implanted in patients who were considered to be neocardiovascular functional class 4, who would otherwise have an increased mortality in 1 year. This group of patients were compared to medical therapy. And if one draws a line, horizontal line here, their 1 year survival is about 25%. So those patients who are in class 4 on continued medical therapy, which included inotropic support continuously, survived very poorly, as opposed to patients who were implanted with a pulsatile device, and there was a survival improvement of approximately 48% to a 1 year survival of 52%. So you are looking at 25% survival versus 52% 1 year survival. Based on this, the left ventricular assist device use increased. So what happens to our patient? Does he need a transplant at this time? What we do and what we did is to figure out where does he fall in in heart failure. Advanced heart failure now has become clear to us, has several shades. And these are the 7 shades that are available to us from the INTERMACS data. INTERMACS is the interagency data for mechanically assisted support devices. And we have collected device over 10,000 patients, and we were able to glean several shades of advanced heart failure. As one can see, INTERMACS level 1 is the crash and burn. This is the patient who is in cardiogenic shock. Level 2 are patients who are on inotropes but continuing to deteriorate. Level 3 is who are on inotrope and stable. And level 4 is resting symptoms on oral therapy at home. Level 5 is housebound, comfortable at rest, but symptoms with activities of daily living. These 4 patients fall into the category of New York Functional Class 4. And level 5, 6, and 7, level 5 is Class 4, and level 6 and 7 is New York Heart Association Functional Class 3. So as we can see now, New York Functional Class is not sufficient to understand these patients. And we have now come to have a better understanding of these patients in order to decide when to implant devices. So there are INTERMACS levels 7 is utilized currently to decide what patients receive therapy and when. This patient's VO2 is 10.9. As I mentioned, he is well below 14, therefore he is a transplant candidate from that perspective. And this is what transplant does. It improves, he has advanced heart failure from the clinical picture that we saw previously. He has his overall clinical picture, and low VO2 predicts poor survival, and his ventilatory efficiency suggests that he has increased mortality. So it is clear that he needs transplantation. So the next step would be to do a right heart cath to evaluate his hemodynamics. And he underwent right heart catheterization, and we found these data. His RA pressure was 10, PA of mean of 35, wedge pressure of 16, mildly elevated, cardiac output reduced at 3.5, SVR, systemic vascular resistance, mildly elevated at 1440, and pulmonary vascular resistance is also elevated. Clearly, this indicates his cardiac output is low. He requires further support for extension of life. He underwent testing in the cath lab with the milrinone for revision of pulmonary vascular resistance. That was not successful, therefore he gets hospitalized. So he's placed on milrinone and hospitalized for further treatment and continued evaluation. The patient develops ventricular tachycardia, receives 3 shocks, and was placed on amiodarone. And from there, he slides down. And as you can see, he is now on milrinone 0.5 micrograms with the hemodynamics mildly improved and has a risk of developing continued arrhythmias. And this is not an unusual situation in a day for a heart failure patient who are hospitalized. They continue to slide. As you remember, this patient came to the office walking in for a transplant evaluation. Now he is placed on inotrope and continuing to deteriorate on inotropic therapy. He started with INTERMACS level 5, and he is now at INTERMACS level 2 on inotrope and deteriorating. What would you do at this time? Would you add dobutamine? Would you place an intra-aortic balloon pump, intravenous vasodilators, or mechanical circulatory support, or palliative consult for comfort care? We couldn't give dobutamine because he's developing ventricular tachyarrhythmias. Intra-aortic balloon pump is a short-term measure. There is no exit strategy. Intravenous vasodilators is not appropriate because he already have a reduced SVR. The appropriate choice is either mechanical circulatory support if the patient wishes it, or palliative care if they choose to go that way. And he received a left ventricular assist device. Now, these are the patients who receive left ventricular assist device. So why is there a need for LVADs? Because we can extend the life of patients who are not transplant candidates, and we can bridge them to transplantation quite successfully with left ventricular assist device. And that is reflected in the data we have collected. This is Intermax registry data over 10,000 patients who are now living 95% 1-year survival. If you remember the rematch trial, there was 52% 1-year survival of these similar type of patients. But now with the continuous flow LVADs, we are able to improve their survival to 95%, and even their 3-year survival is more than what the rematch trial suggested at 52%. What about the quality of life? Significantly improved. Pre-implant, almost 80% of them had significant symptoms, but post-implant, over time, after 3, 6, 12 months, these symptoms continue to get better. So there is improved quality of life, extension of life, benefit by implanting left ventricular assist device. As a result, you can see over the past few years, our number of implants that has been implanted across the country has significantly increased to between close to about 11,000 implants in the past 10 years. So that is reflected by the growing need for the LVAD. This is also true for other devices such as total artificial head, and this is a data again from Intermax that tells us not only the continuous flow LVADs, but also total artificial heart use has increased over time. There is some pulsatile flow utilization, but a lot of people are moving away from using pulsatile flow because of the durability of the continuous flow. Now this is my concluding slide, where you find increased use of LVADs, and these patients are now living longer, requiring continued coronary intervention and electrophysiologic ablations to alleviate other comorbidities so that they can live longer and be comfortable. Thank you. Yes. Here are my questions. So Intermax levels in advanced heart failure refers to New York functional class 1 patients, class 2 patients, 3 patients, or class 4 patients. Excellent. The left ventricular assist device support in advanced heart failure is considered because it offers improved quality of life, improved functional capacity, improved neurohumoral milieu, and improved survival benefit, or all of the above. Fantastic. Excellent job.